Hello and welcome to Breakpoints, the Society of Infectious Diseases Pharmacist podcast. My name is Erin McCreary, and I'm the Director of Infectious Diseases Improvement and Clinical Research Innovation at UPMC.
And hello, and welcome to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner, and I am the Editor-in-Chief of CMI Comms and an infectious disease physician at the Geneva University Hospital in Switzerland. Today, we are bringing you the second collaboration podcast between Communicable and Breakpoints. This time, we'll tackle the recently published BALANCE trial, whose lead investigators we're thrilled to have with us today. It is my pleasure to introduce Nick Daneman, Professor of Medicine at the University of Toronto and infectious disease physician at Sunnybrook Health Sciences Centre, Toronto. Nick has a long history of research into the use of antibiotics and their delivery, specifically maximizing their benefits while minimizing their harms.
Thank you so much for this invitation and this opportunity to talk about balance.
And then next, we have Rob Fowler, also a professor of medicine at the University of Toronto, a critical care physician for the Department of Critical Care Medicine at Sunnybrook Health Sciences Centre. Rob, welcome to Breakpoints and Communicable.
Hi, both. Thanks so much.
So as our listeners know, at Communicable, we start these episodes with a get-to-know-you question. So here's the question. We're coming to end of summer, and some of us might have gone to some cool concerts. What is a concert you would want to attend, or maybe already did attend? Nick, you first.
I guess for me, that's Billie Eilish. My kids really got me hooked on her music over the last few years, to the point where she was my number one artist on Spotify 2024 Wrapped. And the missed opportunity for concerts is pretty fresh in my mind. So we came back from this glorious family holiday in Japan over the last couple of weeks. And on that very last full day of the trip, we were walking in Shibuya, Tokyo. And my daughter Chloe looked up at me with these really big eyes and said, "Dad, Billie Eilish is playing here tonight in Tokyo." And there was that moment of thought, but I dismissed it almost instantly because it would be impossible to get those tickets. And if we got them, they would have cost a fortune. But just thinking back on it, that would be just an incredible ending to an incredible trip.
Wow, you should have gone.
Rob, you're up next.
Yeah, I like Billie Eilish too. But last year, I wasn't able to get to a Bruce Springsteen concert in Toronto that we had tickets for, but my wife was able to enjoy with a friend of hers. So I'm hoping to catch up with him on tour somewhere in the future.
Very cool. Yeah, that would be on my list. Definitely. Erin.
Okay, this is acute in my brain, and much to anyone who listens to Breakpoints or Communicable and has heard me talk, I'm actually not going to talk about Taylor Swift. I just saw Gracie Abrams at Red Rocks out in Colorado. But for those of you who may not know, Red Rocks is an amphitheater that's truly built into the mountains. And so you have to hike up, and there's 70 something rows, and each one goes up quite a bit of elevation. And it's just carved into the mountains right on the west side of Denver. And it is stunning. And it is everything you'd ever hope from an acoustic standpoint, from music. Last week, I took my stepdaughter to see Gracie Abrams, and it was truly one of those insane life moments where the concert was on a Tuesday night. So we flew out Tuesday morning, landed in Colorado at 10 a.m., got ready for the concert, went to the concert, and then flew home Wednesday. But it was worth every minute of insanity. It was so fantastic. It was awesome.
Yeah. Well, my concert experience already happened, and I really racked my brains, and I could not think of a future concert that I would care more about than the one I already went to last year. I went to Taylor Swift in Zurich, and it was so cool. Because I didn't expect ever to be able to go, because I knew it was impossible to get tickets and everything. But 2 days before the concert in Zurich, we just looked online and there were tickets available for my daughters and me. And we all just did a road trip and went to this concert 2 days later. And I've been to some concerts in my time, and I'd never really experienced a concert like that where somebody works so hard to make people happy.
So anyone listening to this right now, the moral of the story is pause, buy the tickets to the event you've been thinking about. Just do it. Just do it. You only live once. There's been many a thing I haven't done. But things we have done are very cool clinical trials. So let's pivot now and get back to our topic. So today we are talking about the BALANCE trial. This trial was presented as a late breaker at ID Week in 2024 and then published on November 20th, 2024 in the New England Journal of Medicine. We cover actually Nick's ID Week presentation on the Breakpoints podcast in our December 20th, 2024 episode, which is titled ID Week 2024 Late Breakers Recap. So if you want the quick summary, please feel free to listen to that. But for now, be warned, we're going on an epic journey and we're going to deep dive into all things that went into this trial. And so, Nick and Rob, we really want to hear about this long arc that brought you to do this trial. It took 10 plus years to complete. And Nick, I think let's start with you because you explained in your ID Week presentation that you guys did a lot of retrospective studies and even national surveys across Canada, Australia. So you guys are now doing all these very complex, adaptive, randomized trials, but you started somewhere. So can you give us an idea how you got from there to here?
Yeah, it's pretty hard to believe that it all started as just a hallway conversation between me and Rob, debating a patient that he was following on the critical care unit that our stewardship team had recommended, upping the duration of treatment instead of decreasing the duration of treatment to 14 days because they had a positive blood culture. And that was just the standard of care at the time. Everybody with bacteremia got 14 days of treatment. But as we're having the conversation, we felt really uncomfortable with it. There's really no data to support this. It feels like expert opinion. So why don't we try to answer this question? Right from the beginning, though, we know that it's a very large randomized trial, but we don't want to jump right to that. So we wanted to lay the preparatory work to see that there was practice variation, equipoise, the need for a trial, and then how to best design that trial. And so our research program started, I think, as pretty much every research program should, with a systematic review. We looked for randomized trials comparing short versus long duration treatment in bacteremia. Pretty much none existed at the time. So we saw that evidence gap. We did find that it probably was okay to pursue because there were lots of trials of short versus long duration and other syndromes that can be complicated by bloodstream infection. And then the next step was to ask, in the absence of evidence, what are people doing? So like you said, clinical practice surveys, I find them one of the most fun and informative studies to do. They don't even require any money. And so we asked ID doctors, ICU doctors across Canada, later on in other countries as well, how long are you treating patients with bloodstream infection? And we found 14 days was the most common duration for almost all pathogens and syndromes, but there was huge practice variation, lots of people giving 7 and 10 days, and clear stated explicit willingness, I would enroll my patients in a trial if you were to do one. That's when we engaged the Canadian Critical Care Trials Group, and they bought into this research question. 11 people put up their hands saying, our ICUs across the country will join a retrospective observational study. That showed the same practice variation and even longer treatment durations than what we were seeing in surveys. It wasn't just like a mode of 14 days. The median treatment duration people were getting in real life was 14 days. The next step from there, I would also highly encourage anyone that's going to do a large trial to take that step, is a feasibility pilot. Not a mechanistic pilot to try to show glimmers that an intervention worked in an underpowered way, but to enroll people and show that it's feasible to do, that you can get people to recruit into a study. So we started a pilot in ICUs, starting at Sunnybrook, our hospital, and then rolling out to some others, and showed that it was really quite feasible. And that became the vanguard for our main trial.
I think it's so interesting that you started in the ICUs. And maybe not. Maybe people are like, obviously, that's the place to start. But in a way, it's like those are sicker patients. We see with drug trials, like that's harder patients to enroll. But is it because, Rob, you were working in the ICU and those are where patients with bacteremia are initially presenting and it would have been harder to find these patients on the ward? You're obviously not stable in the first 24, 48 hours if you have bacteremia. So kind of describe to us why you went to the ICUs first.
Yeah, it's a great question. That gets to, I guess, a very practical reason that Nick alluded to, and that in Canada for over 30 years, we've had this terrific group called the Canadian Critical Care Trials Group, which does a lot of foundational research that oftentimes culminates in a clinical trial. And so there was a network of very interested investigators, research coordinators, methodologists, and really already mentoring and helping lots of groups answer questions like this. It became obvious that we would go to a group that I knew pretty well and Nick had engaged with to try to get a combination of mentorship and help, and then also help with operationalizing the studies that lead to a trial like this. The sorts of studies that Nick alluded to, they're foundational ones for a trial. And oftentimes, if we don't do some of this work up front, then something pops up when we're trying to do a trial that we say, oh, I wish I had known this earlier, or I wish I had discovered this earlier. They can really throw a huge wrench into a lot of work for a lot of people. And so I think it's super helpful to be able to do this work ahead of time, but it's also, I would say, super responsible to try to do this work ahead of time so that at the point when you're engaging patients in an experiment, one treatment or another, that you've done as much as you can do up front to make sure that experiment is as appropriate and efficient and will be as helpful as possible to future folks.
That's fantastic. I love that.
So can we just step back and run down sort of the big overview of the trial? For those who have not actually read it, there may not be that many out there who haven't, but just in case.
Yeah, sure. So the question of shorter versus longer duration antibiotics, that's a pretty ubiquitous one in treating patients with infection. As Nick mentioned, our original question was focused on antibiotic durations and was focused on a critically ill patient. Common syndromes there are ventilator-associated pneumonia and bloodstream infection because of catheters and urinary tract infections that lead to bloodstream infections, etc. There had been this really informative trial examining essentially 1 versus 2 weeks of treatment for ventilator-associated pneumonia back in about 2003. I remember I had done an observational study looking at treatments for ventilator-associated pneumonia when I was in training and helped with some practice guidelines, but was impressed at how difficult it was to know if someone had pneumonia or not. And so Nick and I remember discussing that when we were thinking about syndromes that would be important to study in critically ill patients and eventually in the whole hospital. We performed our initial pilot after the foundational work among hospitalized patients who were admitted to the ICU with a blood culture that was positive for a pathogenic bacteria and randomizing eligible patients to 7 or 14 days of appropriate antibiotics, so appropriate to their culture and sensitivity. Our pilot trial, the outcome was feasibility, so recruitment rate and protocol adherence. And we measured in parallel the outcomes that we'd want to use in a larger trial. And that pilot was pretty successful in terms of the feasibility and was certainly instrumental in starting the main trial with the same intervention and comparator with a primary outcome of 90-day mortality. And we're seeking non-inferiority of 7 versus 14 days in that distinction as opposed to superiority, because our starting point was that probably a week is maybe just as good as 2 weeks, a good question to study, within a non-inferiority margin of about 4%. And practically, this meant we'd need about 3,600 patients to gain enough confidence that the answer was true. We subsequently expanded our population to include all hospitalized patients, but not before we conducted a separate pilot trial among non-ICU patients and found that the trial procedures were still feasible at the hospital level. Interesting to us, and we knew this a little bit, but we didn't know it in absolute numbers. There were probably 3 to 4 times as many patients with bacteremia outside the ICU as in the ICU. And so that was a big practical help with eligibility once we expanded to the rest of the hospital.
By the time we made that hospital-wide expansion, our inclusion criteria become very simply, you're hospitalized at the time your blood culture dings positive in the lab. And then the exclusion criteria, we try to keep them as pared down as possible, only excluding the most severe immunocompromise, which is neutropenia and transplant, only really excluding one common bacterial pathogen, Staph aureus, common contaminants, especially when they're relevant for them. And then the syndromes where we know we need longer treatment, which when we set into this, I would have thought would be a longer list. But when it comes down to it, it's endocarditis, bone and joint, undrained abscess, or unremoved prosthetic infection. A pretty short list.
I did notice that you excluded people who simply had prosthetic valves, like even without necessarily suspicion of endocarditis. But you said, no, we're not going to take any chances on that.
Our feasibility pilot was so feasible that we didn't make many adjustments at the time of switching over from Vanguard to main trial, but that was one tweak to the exclusion criteria. We added prosthetic valve because we had run into the concern around some of the organisms like Enterococcus where people feel less comfortable. It wasn't really relevant to the gram negatives, and so it would have been easier to allow it in. So it's probably one of the reasons why I didn't even mention it when I was running through our exclusion criteria, because I don't think of it as one of the main most important ones.
Yeah. Just thinking you don't want to tie your hands when you're recruiting, right? And now with these aging populations, there are so many prosthetic valves out there. So it would be a shame, I guess, to bar yourselves from those patients if they just have an E. coli bacteremia, for example. Yeah. But clearly, you guys did fine. You recruited tons of patients, but I guess it did take you a lot of years.
Yeah.
And a lot of hospitals.
There was a COVID pandemic in between that slowed things down quite a bit. And some of those early years, the ramp up, that Vanguard phase gets included in the total duration. The actual trial really only launched as a main trial around 2016 or so.
So let's frame that for the audience. So you guys did end up randomizing 3,631 patients from 74 hospital sites in 7 countries over 10 years. That's a lot of work. That's pretty incredible. I want to just real quick go back to the fact that this was incredibly easy and very broad inclusion criteria. And you said your feasibility was so feasible and you intentionally made that very broad. From collaborating with folks in Canada and Australia, you guys are really good at doing pragmatic, low barrier to entry trials to answer these very relevant questions. I would say in the United States, we're not so good at it. Our trials tend to exclude a lot of people. It gets to the point where then you're like, this trial is great, but finding this diamond in the rough of this patient that exactly applies to the trial population, it's challenging. And so the trial's less externally valid. It feels intuitive, but can you just state for our listeners why your team and collaborative said, you know what, we're going to keep this very easy and very broad and kind of take this almost all-comer trial outside of staff in Canada?
That's a great question. We did start from a point of wanting answers to be as relevant to as broad a patient population as possible. And I think we're very actively thinking about every exclusion criteria. There are some that are in the balance trial that I think if we were going to do it again, we would say, we take even more of those exclusions out because we're left thinking that we don't have as much information as we should to generalize even the results that we do have to some of the other important patient populations. And so I think, if anything, we'd want to be more pragmatic, have fewer restrictions in our subsequent work. When I had just started as a clinician at Nick and my hospital in Toronto, one project that I had done with a resident at the time looked at exclusion criteria, eligibility criteria really of high impact trials in the medical literature at the time. And it was so interesting to find, I would say, a usual laundry list of exclusions that when we went through and tried to justify in the context of the intervention and the patient population, we were left scratching our head as to why wouldn't this be something to learn about for pregnant women? Or why would it be that a 14-year-old may not benefit from knowing the results? And that certainly informed a lot of decisions that I've been thinking about over the years.
I love that. That is very helpful too. So tell us who ended up being in this trial. What were your demographics like in the population enrolled?
So among those, eventually 3,608 patients that you mentioned, there were slightly more males than females, and that's not uncommon for a large trial that enrolls a large proportion of patients in the ICU. So about 55% were male, median age is 70 years, comorbid conditions that you might expect. So about a third with diabetes, a fifth with cancer, about 10% with some degree of renal insufficiency or on dialysis, heart failure, and COPD. One measure we collected, the frailty score, found that patients were commonly with some degree of vulnerability, sort of in brackets, and they didn't need daily help for things, but things that might just slow them up a bit. So a hospital patient population that we might imagine seeing on our wards in ICU. About 3/4 of the patients had developed their bacteremia while in the community before presenting to the hospital. And of the common syndromes, urinary sort of syndromes leading to bacteremia, most prevalent at about 40%, 20% intra-abdominal, 13% with a lung source, and 7% catheter-related. And accordingly to the syndromes, E. coli was the most responsible causative organism in just over 40% of infections, with other gram-negatives and positives, as you might expect in any bacteremia observational study, with the exception of Staph aureus, which was an exclusion criteria.
And 55% of your patients were in the ICU. 21% were intubated and 30% were on vasopressors, I think, at the time of enrollment. I don't know about you, Angela, but for me, for my institutions, this is what was really meaningful for us, because I think at this point, people are comfortable treating stable patients with a little less if possible. I think in general, the world understands we want to limit antibiotic exposures whenever we can. But admittedly, even those of us who have adopted some shorter course paradigms for any disease syndrome, often our guidance is, okay, but they have to be totally stable. And so this really expands to quite a sick population and then quite a patient population of advanced age. I think your median age was 70 years old. So that's what really stood out to us from this trial and the patients who enrolled.
Can you guys actually tell us on what day of the bacteremia did patients get randomized? Because I didn't actually see that in the main text.
Yeah, we encourage people to approach as early as possible and randomize as early as possible, but they were allowed to randomize anywhere up to the 7th day of adequate
wow. Treatment. Okay, and what was your median?
It was going to be around 4 to 5 days.
Okay, so kind of after that acute illness, yeah.
Yeah, because I could imagine that it would be hard to get buy-in from your physicians to say, well, you guys have to randomize this patient who's in the ICU on day 1 or day 2 don't know how he's going to do, but randomize him now to 7 days or 14 days. Make that decision now. Whereas clinically, we don't really make that decision right off, right? We're thinking about the choice of antibiotic we want to give, the way we want to administer it. We're not necessarily thinking about duration at that point because the patient's in the acute phase.
I wanted to encourage early approaches and early randomizations because another decision for design could have been, and there were a couple of team members that had recommended this, would be to randomize only on day 7. And then you're either stopping today or you're giving another week of treatment. You're going to get less protocol non-adherence then. I'm sure we'll come back to protocol non-adherence, but you're changing the question. And I think that really does impact generalizability because you're really focusing only on the patients that are really well by day 7. We wanted this to be a treatment strategy trial. From the beginning, would I be comfortable treating people with bloodstream infection with 7 as opposed to the traditional 14 days of treatment?
I mean, yeah, in a way, I think you did kind of a massive sensitivity analysis. You basically said, okay, we are going to be blind to how this patient's actually doing at the time when we need to make a decision as to stopping or continuing. We're going to preempt that, and we're going to already determine the duration, no matter what's going to happen with this patient in the next 72 hours, the acute, really early onset where the bacterial loads are still really high. And so you did it upstream, and it still showed non-inferiority of 7 days. So it's like really rock solid. Right? That's how I take it.
You make a good point there. I guess we didn't say explicitly. There was prolonged allocation concealment so that if you randomized on day 1 or 2 or 3 or 4, et cetera, the team wouldn't get to know what group they were in until day 7.
That's fantastic because you don't want the team changing their behavior when they know. You don't want them getting a full body CT scan or something the night before stopping the antibiotic. Yeah, make sure there are no abscesses.
Angela, what you just said is actually so important. And it sounds like Nick and Rob, you appreciate this amongst your colleagues and peers, is that this is all about changing behavior, and science's data is important, but it really comes down to behavioral change and management. And there's a lot of mind over matter here. So I think if you had approached people on day 7 and said, you need to stop today, you would have had a lot less buy-in. People are not mentally prepared for that, especially back then when they were enrolling before it became kind of something we accept now, especially in the gram-negative space. You're giving them a couple of days to mentally brace for the fact that they could stop at day 7, and they've accepted that. They're ready for that change. And Angela, like you just said, they're not like, well, I might stop, but let me do all this extra imaging and just be super sure, right? We want to first do no harm, but often extending antibiotics doesn't necessarily not do harm. And so I love that it was the intention of 7 days is acceptable, and then that leads to more overall buy-in.
As you said, this notion of changing behavior is so challenging. And even in the context of the trial, I think we could appreciate qualitatively that the first enrollment for any particular clinician probably was associated with a bit of nail biting on the treating physician's behalf when it is potentially changing a treatment strategy that we've become much more accustomed to, longer durations. And I think as people went through the trial, and we see this at individual hospitals, got a little bit more comfort, the randomizing early. So after we have an organism identified, and it became much easier as people got more comfortable with the concept. And I think that sort of mirrors probably outside the trial as well, but it takes some time for people to warm up, as you say. Maybe randomizing a few days ahead of the stopping point was helpful in that way. Yeah.
Interesting. Yeah, I think we both have so many questions, and I'm going to try to keep them ordered, try to follow a certain line. So we are still officially at screening and recruitment. In terms of actual inclusion, if we take the consort flowchart, you did screen over 36,000 patients. Congratulations just on that. That is a huge feat. That's really a lot of work, and bravo to your teams. You screened 36,000 for eligibility, and we know that ultimately 3,600 were included, but 13,000 would have made it in. 10,000 of those 13,000 didn't get in because they either declined to participate or their physician declined participation. Speaking of pre-standing biases. So in the end, only 10% of all patients screened made it into the study. How much do you think the non-inclusion of those specific 10,000 that would have gotten in based on their medical profile, how much could that have changed the results? How representative are those 10,000 that didn't get in because they declined or because their physicians declined?
Yeah, it's such an important observation. I would say trials often have this very humbling flow diagram where the top number to those that are enrolled and followed up, and depending on the trial, but it's frequently in this sort of 10% range. Even in this case, despite trying to make the eligibility criteria pretty broad and minimize exclusions, of those 13,000 eligible patients, really, about half the clinician or the patient or the SDM declined to participate. I don't know that we can say this to be true yet, but suspicion is that number diminished over time as people became more comfortable with the trial. Some patients had no one to provide consent, but that's a minority. And very few eventually, once they got into the trial, withdrew. And so that's good. But the generalizability question amongst a lot of patients that are not in the trial to begin with would probably, as you've highlighted, track along lines of, the very sickest of patients. Sometimes people would have some concerns about patients that were very likely to pass away in their minds, etc. Or on the flip side, a patient that's super well and they think, oh, yes, they were uroseptic and got bacteremic, but I think I'm going to send them home tomorrow, or I think I'm going to send them home in a day. Some of those patients are not going to get in, and for sure that's important. Having said that, looking at the eventual patients that did get in, Erin, as you highlighted, there were a lot of sick patients in the trial. And so even though we had a big drop off from eligible to those included, I think the spectrum of demographics and characteristics of the patients eventually enrolled help us feel a little bit less bad about that typical drop off in the consort diagram. So I think we still got a broad spectrum and a lot of patients that were really sick. But you're right, that typical everyone you screened, everyone you included is often a pretty humbling figure.
Yeah. But you know what, too? I was thinking about this because now it's like, 7 days, right? We give 7 days for pneumonia, blah, blah, blah. But 10 years ago, you're asking people to cut the treatment duration in half. That's a big ask, I think. And so it's amazing that so many people did to flip it.
Even with those refusals, when you look at the patients imbalance, they look almost exactly like patients in a bloodstream infection registry or observational cohort, right? You have median age 70, slight male predominance, almost the identical frequencies of comorbidities that I would see when I do like a population-wide study here in Ontario. And then if you look at that top pathogen list, it's almost in the exact order from the surveillance networks. The only one missing is Staph aureus up at number 2 after E. coli because we excluded it. So I feel pretty good about the people that got in, even though we'll never know for certain about those folks that didn't decide to take part. Participating in SNAP, I'm also reassured by the fact that another very large bloodstream infection trial sees almost the exact same 30% consent rate among eligible patients. You're just not going to get everybody agreeing to a trial when they're super sick, regardless of what the question is.
So about 10% was excluded for Staph aureus, which would put that you had about 45% E. coli, 15% Kleb. So urinary source is what we expect, abdominal. Staph would have been your number 3 here. And then Enterococcus as your 4th, 7% had Enterococcus. But just to round out our conversation about the consort, something that really stood out to me, probably because I do a lot of quality work, was that 10,000 plus patients were excluded because of a contaminant, which when you do the math, 29% of patients had contamination, which is why they were excluded. That is a crazy amount of contamination, right? Just like as a side note, there's all these pearls we can get from these trials that teach us about practice as a whole, other hypothesis generating things. And like, wow, we have a long way to go in blood culture contamination. But to move on, balance was essentially randomized 1-to-1. You guys stratified randomization by ICU admission and hospital site. You talked about how it was a prolonged allocation concealment to day 7, open label, no placebo, and we ended up with these 3,600 patients. So let's talk about the pathogens, because gram-negative, we feel good about, but you guys did. You had 7% Enterococcus, and then when you add up all the species of Streptococcus, you're at about 10% having Streptococcus too. So there's a lot of gram-positives. Did you have a pre-trial probability that you would be so successful enrolling the gram-positive patients?
Not sure about a pre-trial probability, but we felt optimistic, and I think it was one of the value adds of all that preparatory work to be able to see that people had equipoise and practice variation in the treatment of those organisms. So it helped in terms of us designing the trial. It also helped with site startup visits. So we were able to present that data and say, look, you may always treat this for 14 days, but look at your colleagues across ICU and ID and internal medicine. They're giving 7, 10, or 14 days, hugely variable treatment. And even the ones that are giving long treatment are saying explicitly, I think I'm giving too long. I need some evidence to shorten my treatment. So at least the preparatory work seemed to show that we should be able to enroll these patients.
This is a bit of a tangent now to the question, but Nick's comment around the importance of doing surveys and observational work. There's a number of times when we presented the idea to different groups and were met with a very reasonable comment that, oh, we never do that, or we would never really treat that long anymore. In Canada, at least when we had those conversations, we asked people, what do you think you do? And state perceived practice. And then you go and measure and you realize, oh my goodness, that's not all we really do. So it was really informative to do some of that comparative work about what we think we do and then what we actually do. For lots of reasons, the amount of antibiotics administered don't end up mirroring what we might hope or what we might think we do. So it was super important.
Your trial, because it spans so many years, from the beginning to the end phases, did you notice a difference in culture, really? In the very beginning, was it harder to get people to accept 7 days versus the end? Because by the end of your trial, 2 other randomized trials were already published. When you started, those 2 trials were just taking shape. One was, of course, Daphne with Michael Paul in Israel and in Italy. And the second one was our Swiss trial, which I wrote the protocol not knowing you guys were already on your way. 10 years later, we had Daphne's results, we had the Swiss results. Did it almost flip towards the end? Were people like, oh, I don't really want to give 14 days. Why would you have us do that now?
I would say there was a huge culture shift promoted by your amazing study and Daphne's amazing study, where the thought 7 days then was what many people would see becoming the standard of care. So we could still have people be willing to enroll into our trial and have equipoise because we would be able to replicate the results, but with the added sample size, increase the precision of the cumulative findings. So hopefully there weren't too many people not enrolled at the participating sites because of the existing data. I think that those studies really helped get people wrap their heads around the idea of the value of shortening treatment duration and the safety of it.
It was interesting. When we started, what we had to do, Nick, was we actually looked at the pediatric literature to kind of comfort people, to reassure our funder, this National Science Foundation, and the doctors when we first started recruiting, because pediatricians are very good at giving short durations. At that time, you could only find it in pediatric literature that people were giving even under 7 days. And that actually really helped our argument. But when we started, there was nothing. All the retrospective data we could find were much more for longer durations. So it was very hard to reassure people until we found the pediatric literature, actually. Because we did have that extra arm. We had this crazy CRP arm where we actually stopped treatment at 5 days if the CRP had fallen by 75%. So that scared some of our doctors, I think, in the beginning. We had to reassure people a lot. But then Daphne's study was published, and it really did help us, I would say.
What would be super fascinating would be a longitudinal observational study looking back over the last maybe 20 years to antibiotic treatment durations for bloodstream infection. We have great population-based data in our province, Ontario, with 14 million people, but we lack inpatient medication use. The detail that we'd love to have in it, but if we could somehow look, it'd be really neat to see how things shifted from by the time the balance started to the time the balance finished, with your study in between and Daphne's study in between, and then to see what more work needs to be done.
Yeah. And like you were saying, other populations, right? Like we felt sort of obliged to exclude transplant patients, certainly patients with neutropenia. And those patients historically get like 3 weeks of, in fact, I think it's still in guidelines to give renal transplant patients up to 3 weeks of antibiotics for bacteremia. David Van Dyne is working on that. He's trying to get off the ground a duration trial just for that population. There's so much more now we can do. I think balance really opens it up, right? Like you've done it for the general patient profile. And on the basis of that, we can now go into different patient populations and be more bold.
Yeah, I always say the best details are always in the supplement. So when you dig into the supplement to kind of round out our conversation about the patients in this trial, to Angela's point, and how this has really just broadened what we think about for shorter courses, you guys also included polymicrobial bacteremias, which I would say have traditionally been excluded. We want to be pure. We want to understand the intervention to the pathogen. But 6 to 16%, depending on what group you look at, were polymicrobial infections. And then you also included non-fermenters. So about 5% of the patients had Pseudomonas. Can you talk to us about the decisions to include those patients? Because honestly, thank you. We're so glad you did.
Rob and I are both pretty pragmatic people. So I think anytime there was a decision to be made, we always lean towards the pragmatic direction. So we wanted to include as many patients as possible to help answer questions that people didn't really have answers to. There seem to be collective equipoise out there for all these questions across clinicians. Any individual clinician may disagree on a specific point. I'm not going to randomize polymicrobial patients, or I'm not going to randomize Pseudomonas patients. But there are other clinicians out there that would, and there were so many sites enrolling, and there was randomization stratified within sites that we were able to address it. I also love seeing that stat, like you said, that 60% are polymicrobial. That's kind of another little piece of evidence that we have a generalizable population.
I'm so happy you guys included Pseudomonas because we didn't, and I always felt bad about that. We had a lot of debate about it. It is a bad organism if you are very immunosuppressed. It's an opportunist. Thank you so much for including it because now you broke the taboo, I think, which we weren't able to do.
One of the things that having such a large number of patients, and as you say, a good chunk of patients that have Pseudomonas and Enterococcus and things that you might be a little bit more interested in getting into the details about how those subgroups performed with the intervention. And that's something that we can tease out a little bit and hopefully in the near future be able to give a little bit more information on that.
We're very diligent in not looking at them during the initial study manuscript production and adhered really closely to the statistical analysis plan so that we wouldn't be multiple hypothesis testing. But there's definite plans to pursue some of these subgroups.
Yes, we need to know this. Very excited to hear how it went by pathogen.
It might be time to move on to the main results, which we've alluded to for sure. And people probably know because they've read the trial, but drum roll, please. Nick, do you want to do the honors and share with our listeners what your primary outcome ended up being?
Yeah, so our primary outcome was 90-day all-cause mortality. We feel like that's pretty objective as it gets and patient important. In the 7-day treatment arm, 14.5% of people had died by day 90. In the 14-day treatment arm, 16.1% of patients had died by day 90. So the risk difference is minus 1.6%, actually favoring 7 days of treatment. The 95% confidence interval spans from minus 4.0 to plus only 0.8. So that upper limit, plus 0.8, is really far from that plus 4% non-inferiority margin. So we can say really clearly at the end of this that 7 days treatment was non-inferior to 14 days treatment for the outcome of 90-day mortality. That was in our intention to treat analysis. We also ran a per protocol analysis where we limited it to the people that got within plus or minus 2 days of their assigned duration, same result, and a modified intention to treat analysis where we removed anybody that died in the first 7 days of treatment, which is before your treatment arms diverged, and again found the exact same thing. And our results were also consistent across secondary outcomes of interest and also pre-specified patient pathogen syndrome subgroups. So a pretty consistent finding to say that 7 days of antibiotic treatment is non-inferior to 14 days of antibiotic treatment for patients with less treatment.
I think in infectious disease clinical trials, it's rare to have such tight confidence intervals, and it's beautiful. We don't often get that level of certainty, so thank you.
Took a long time to get there. We're starting to see that more and more, though. I mean, look at the Bling-3 trial, incredible, like enrolled 7,000 patients, such a tough intervention to study. It's amazing because some people call that a negative trial because I think the p-value is 0.06 or something, but you have 7,000 patients, you're not going to get more than that. And you have very tight precision around the estimates. So we know the answer of how much it works, and it works a modest amount.
I think we have to thank Canada, Australia. These are countries that are ready to fund, to the degree that's needed, good clinical trials where we actually get to answer questions and not lead to more doubt because, the results sort of neither here nor there because the power is missing. It's nice to see this trend even in our field, even in infectious diseases.
Well, to quote our good friend Vance Fowler, who wrote the editorial for this trial, who said, you guys did such an amazing job, such an inclusive patient population, such precise results, non-inferior across all three analyses. The only thing this trial is missing is the United States, which is true, right? We couldn't enroll patients in the United States because of some barriers here, but all in all, just so amazing. Did anything surprise you about these results? The data comes in and you get to open it with your investigators. Is it what you were expecting or were you surprised?
I think we started with this notion that 7 was probably as good as 14 to sort of phrase non-inferiority in common terms. But I don't know, I have to admit that when we were unblinded to the findings, the notion that 90-day mortality veered towards an improvement for the 7-day treatment group. I mean, I don't want to overemphasize that. And it was fairly consistent across the pre-specified subgroups. I think that was, if not surprising, it was intriguing and a bit reassuring that at least the directionality was in a way that we had wondered about and hoped, but you don't know until you do the trial.
May I interrupt you there, Rob? Why would there be this directionality? Was it like C. diff for everyone who got 14 days and they dehydrated? What were the costs of having 14 days of antibiotics that could explain the difference in the end?
Yeah, it's a great, obvious question. I guess to be clear, we showed non-inferiority. We didn't show that one treatment strategy is better than the other. And so you'll get a point estimate that's not going to be bang on zero, but it's going to be a little bit on one side or the other. And so just to say they're non-inferior, we upfront wanted to look at these reasons why it could be better or it could be worse. And from the data, I don't know, Nick, I don't think we have anything that we can point to that says this is the intermediary or the mechanistic result that helps us understand that there is really any difference. It was a bit surprising to show a shorter hospital length of stay with 7-day treatment, and that as an outcome as opposed to mortality. We could say, well, you're thinking about 7 or 14 days of antibiotics, and some people are on IV, and maybe there's some practical reasons why people might be able to get out of hospital earlier. You come up with a rationale as to why that might be the case. But in terms of like mortality, non-inferior, encouraged that it's going in the direction of our original hypothesis, but hard to come up with a reason why it might be better. Nick, what do you think?
Yeah, for me, pleasant surprise that the point estimate was so far favoring 7 days of treatment. I don't know for Andrew's question. I guess dysbiosis and antibiotic resistance and the sequelae of that, we weren't able to show that in this study. We captured antibiotic resistance only through routinely collected clinical specimens. So any other blood cultures or urine cultures or other specimens the patient had collected and follow-up, most of which would have been in the index hospitalization. So we don't have super rich data capture on that. So if that's the mechanism, I wouldn't necessarily be able to establish it.
To me, as a pharmacist and a steward, and Angela, you mentioned we like to talk about C. diff, and of course that is a concern. And of course, antibiotic exposure is our most major modifiable risk factor for C. difficile infection. But now that we have more large trials in the ID space, we continually see a C. diff rate less than 2%, and even in arms. You would hope to see the 14-day group would have, 8% C. diff rate and a 1% in the 7-day, and we could really pin to that. And repeatedly, we've seen in very large trials that's simply not true. C. diff is actually quite rare still, thank goodness, and despite more antibiotic exposures. So that's interesting because that's clearly a steward thing we hang on, right? Is like you want to decrease your likelihood of C. diff. But let's talk a little bit about your subgroups. That's the punchline. That's the 3 groups in the main study. So I think now with the trials, with Angela's fantastic trial, your trial, the other trials, I think for gram-negative bacteremia caused by a urinary or intra-abdominal source of source control, 7 days, the end. Like this is the nail in the coffin for that syndrome. And hopefully people are on board with that. And I don't think there's a lot of debate in the community anymore. ICU patients, though. So when you talk about the patients that were enrolled in the ICU, that confidence interval is much wider. And then when we get to the Apache scores greater than or equal to 25, or patients who had vasopressor use, then you start to cross that line and you get to perhaps within that subgroup where it's not non-inferior. Now, we can't make a call on the subgroup, but what are you guys hearing amongst your community? What's the debate here? Are people like, yep, I still feel very good about 7 days? Or are they saying, those bigger lines make me nervous?
Yeah. There's a great systematic review in JAMA Internal Medicine 5 or 6 years ago, I would say, where they looked at all RCTs that made a subgroup claim in their abstract. And most were not pre-specified. Most didn't do a statistical test of hypothesis, which would be a test of interaction. And 0 were corroborated in future follow-up trials focused on that subgroup. So like most subgroup findings tend to be spurious in the end. The other thing I have to say, when people read the forest plot of subgroup figure 3, the eyes get drawn to the ends of the confidence intervals and whether or not they're crossing the line. So the crossing line of no difference or crossing the line of non-inferiority. I try to convince people to direct their eyes more to the point estimates because confidence intervals, we draw them as flat, straight lines, but the probability isn't like a flat distribution. Probability is like kind of a bell curve. Most of the probabilities around the point estimate and only the little bits of probability left at the tips. And then we design the trial, the sample size calculation based on the overall study. So subgroups are by definition underpowered for that non-inferiority margin. So in balance, when I look, I don't worry too much about some of the confidence intervals being wider or crossing the line. I feel like my general message when I read down it is that we have a pretty robust finding across the different subgroups. We also did do statistical tests of interaction. None of the subgroups show a significant difference across the different categories of the subgroup. So I feel like for the most part, I wouldn't worry too much about those groups. But I know I'm not going to convince all the critics out there that have particular worries about one group or another.
Yeah. Well, I'm glad you said it You heard it here. At least we can point back to this now, because the same applies then for the other subgroups I think of interest are the gram-positives and the polymicrobials, right? So where you run into that same situation, those confidence intervals are wider. But you're right. When you just look down, those black dots are all beautifully to the left. 7 days non-inferior. To me, I take these data and think, wow, we just have tremendous opportunity for uncomplicated strep, enterococcus. My wheels are already turning in my head for how I can help patients across my massive system. I think it's really important. And something you guys wrote, and Nick, something you said in your ID Week presentation, which I loved, is that really in totality, what we can do with all these data and patients within subgroups is approach it with the mentality that 7 days is going to be okay, and then let the patient guide it. And some patients may need a little bit more, and that's probably okay. But have that mentality rather than saying everyone needs 14 and having to justify less. Go in that says standard care is 7. Some patients, Angela, to your point, may end up at 5. They're totally fine. Some patients may need a little bit longer, but let the patient declare that and have the mentality that 7 days is where we should start. And I love that framing. Well, we've talked about everything we love. Angela, do you want to guide us through some things that we can critique?
Yeah. Can you guys just tell us, what did the reviewers not like? What did they give you a hard time about?
I love that.
Yeah. What were the sticking points with your peer reviewers?
That's a good question. I don't know if I can replicate in my mind what they put on the page, but some of the themes that you've brought up, I think, are ones that did come up in the review process. And so for any trial, for lots of reasons, we'd like to blind a number of participants to the intervention, and patients and family and clinicians and evaluators, etc. We found even in the observational study work that it would be practically impossible to blind, for instance, have placebos for all of the antimicrobials that are used in the treatment. And so even though that was one we thought about, we entertained it, it just wasn't going to be possible for this kind of a pragmatic trial. We talked a fair bit about exclusions of patients that I think probably did come up in the review process. And we have to decide if these are generalizable to patient populations that weren't represented as much. And a few populations have come up as we've talked, like organ transplant patients that we excluded, neutropenic patients that we excluded. I don't know what Nick might imagine in redoing the eligibility criteria, but I think now we might think differently about that and say we should consider including these patients. So that came up in the process. And while we can't generalize the results to Staph aureus, there's another great trial ongoing looking at that organism. We certainly talked about it up front. And so other things that I think we might have considered differently and that came up in the review process to some degree. Non-adherence, that's a super important one. We knew there was always going to be non-adherence. And importantly, as you both said, we wanted this to be a trial that clinicians could modify treatments should a patient remain seriously ill or have an unresolved infection with clinical signs and symptoms. On the flip side, I suppose get better very quickly, but that upfront strategy of 7 to 14 days did lead to median actual treatment durations very close to this. But the idea of retaining clinician judgment for individualizing therapy to some degree for very specific patients, hopefully some objective signs, symptoms, etc. But I think the generalizability question we've addressed, the lack of blinding in terms of an internal validity question, I think we just found we couldn't do. And the non-adherence issue, I think to me is probably about the most important one to try to work through and to make sure we can incorporate this into our clinical decision-making at the bedside.
Yes, Rob, thank you. I do think the non-adherence point is very important, and we've alluded to it several times now. For our listeners, I'm going to read specifically what was in the trial. So patients were treated for longer than the assigned duration of treatment in 23.1% of the patients in the 7-day group and 10.7% of patients in the 14-day group, which people are going to cling to that 23% in the 7-day and say, oh, they got 8, they got 10. But 11% in the 14-day group is also kind of a lot. And that's a lot of antibiotics we're giving for bacteremia. So I think both of those are important. And again, adherence was defined in the study as 7 or 14 days plus or minus 2. So if you got 5 to 9 days, you were considered adherent in the 7-day group. And if you got 12 to 16 days, you were considered adherent in the 14-day group. That's also very practical, and we see that even in observational bacteremia studies, which I like. The group out of Hopkins does this very nicely. They say, we intend 7 days and healthcare is imperfect. Operationally, you might get one dose at 1 a.m. that was supposed to be given the day prior. And if you're counting calendar days, if you're on Q8 hourly medicine, what's a day? Is it one dose on any given day? Do you have to get 50% of the total daily dose? And that's, I think, something we struggle with. But I think the cleanest is to do a calendar day, at which point you're going to have this plus or minus. And we've talked about how you guys stated it really beautifully, is that it's the strategy to use a shortened duration that's non-inferior to committing all patients to 14 days, which I think is so important. And then you did that very robust per protocol analysis that was limited just to people who were adherent, and that still showed no difference. So I'm not as stressed about the non-adherence. I know people are. Nick, what are your thoughts on that?
Of all the limitations in the study, it is the non-adherence one that gave me the most angst throughout balance. For the listeners that have had to think through this, in terms of a superiority versus a non-inferiority trial, non-adherence is a way bigger threat in a non-inferiority trial like this. Because in a superiority trial, if you have a lot of non-adherence, it's going to dilute out your signal and you won't be able to find that superiority result. But in the non-inferiority trial, when it dilutes out the difference between the groups, it pushes you towards finding falsely a non-inferiority result. So we didn't want to be able to find non-inferiority when non-inferiority didn't actually exist. I'm personally very reassured by Rob's philosophical approach. Like we've said, that if you think about it as a treatment strategy study, the non-adherence is not as big of an issue. But I imagine that some of your listeners won't be reassured on that point. So I just want to provide some in-press reassurance or under-review reassurance. So Sean Ong is a brilliant infectious disease clinician from Singapore, doing a joint PhD at the University of Toronto with us and University of Melbourne with Steve Tong and Josh and others, and focusing on innovative work in clinical trials. And so one of his thesis projects was using balance. So you had to wait for balance to get done to do this one, but look at non-adherence in great depth. So the first thing we want him to do is look at what are the predictors of non-adherence so that people could learn like what types of patients in balance had treatment prolongation. So the people that had treatment prolonged beyond their duration, be it 7 or as you pointed out, even beyond 14, people over 70 years of age, people in ICU at baseline, people with a high organ failure score, people with persistent fever, people with persistent bacteremia. So a lot of things that kind of maybe make sense. In terms of things that came out as predictors of shortening of treatment, was just vascular catheter source of infection and a highly resistant microorganism, actually.
Nick, did he also look at the day that the patient was randomized? Were those who were randomized earlier on in their bacteremia, were they less likely to be adherent to?
Great question. I don't think we did look at that, but something to look at, because there should be that trade-off of higher potential protocol adherence with earlier randomization. But what I wanted to point out was that Sean took like this plan way further than we had anticipated and actually uncovered in the literature some really novel techniques to account for the impact of non-adherence on the outcome of a trial. So there's some ways of doing this: inverse probability of treatment weighting and instrumental variable analysis, which people have probably seen used in observational studies to account for selection bias. They can actually be used in a trial. No one really does this. I think some systematic review found that only like 2% of trials had done this, but you can use these methods to account for that post-randomization confounding that people that don't adhere are different than people that do adhere. And when Sean applied all these methods, the result of 7 versus 14 days treatment looks exactly the same. So that was super reassuring to me that we can believe the result at 7 days is not inferior to 14 days, and that even though there was non-adherence as we expected, anticipated, it doesn't change that finding really. So that will hopefully be in that infectious disease journal for people to look at sometime soon. That might make people feel more comfortable about shortening.
That's really great that you guys actually turned this into a subject of study. I want to learn more about these methods because it's obviously a problem that comes up again and again. Oh, my patient's different. I agreed to randomize, but no, it's not going to work for my patient. It's that tension, right? And as we get more emboldened to question dogma, to question guidelines, non-evidence-based recommendations, let's say, need Sean's methods because there always will be this problem of non-adherence. I think we, as reviewers, as readers, we need to simply understand that you're never going to get perfect internal validity, not if you want it to be externally valid.
Can I ask 2 questions that we had no good place to put them? We can do like a little rapid fire wrap up of the supplement mostly. So in table S6, you said patients that received, quote, any enteral treatment was about 60%. Okay, so 60% of patients got some kind of oral treatment. Can you guys clarify, was that all step down, everything at the end? Or were there, dare I ask, were there any patients in the study who got exclusively oral or oral upfront or things like that?
Hey, Erin, aren't we not supposed to say step down? Early oral switch?
Early
Yes.
oral, so EOS.
Yeah, step down would imply that it's not as powerful if it's oral.
Okay,
So you
you're
can't
right.
say step down. Yeah.
Okay.
Yeah.
Stepped up to oral. It's better.
Step sideways. Switch.
Control F, find, step down, change to, switch.
Okay. But that was all therapy continuation was 60% on orals. That's also, again, that's not really what you sought to study, but that's a lot of patients. That's a lot of people we're treating with oral therapy and feel comfortable treating with oral therapy, which I think is an important take home from that as well, because that was all clinician guided. You weren't telling them to do that or not do that. So I think that's very important. And then this happens all the time clinically where we have a patient, E. coli bacteremia. They perhaps are on inactive therapy at the get-go, but then by day 2, they're better. They are clinically better, and we don't get their susceptibilities till day 2, day 3, sometimes day 4, just depending on your lab or whatnot. And you get those susceptibilities back, and you're like, oh, shoot, they've been on piptazo, and it's an E. coli with an interesting phenotype, and it's piptazo resistant, but ceftriaxone susceptible. And then we have this existential crisis of, do I need to now give them 7 days and not count the first 4 days, even though the patient's better? I think in your trial, day 1 counted as the first day of active therapy, right? So those patients that were on inactive therapy. Okay, so Nick is giving me a thumbs up for people listening who cannot see him right now. But
Answering the second question first, it was based on the number of cumulative calendar days in which you got at least 1 dose of a drug active against your index blood culture pathogen that got you enrolled in the study. Time couldn't go back to before that blood culture is collected. So even if you were on something a couple of days before the blood culture is collected, blood culture collection date at most could be the first day. And each day thereafter that you had something active. We couldn't take into account pharmacokinetics and pharmacodynamics and dose and frequency, and we left that all up to the treating team. For your first question around the switch, it was, I think, 99.3%, I want to say, had at least some intravenous treatment. So these weren't people typically being started on oral therapy because it was such a sick population with bloodstream infection. Almost everyone got intravenous. And then, like you said, 60% got some oral along the way. And there'll be more in the 14-day arm that got oral than the 7-day arm because they're on treatment longer and had more opportunity to switch over later in the course. And we do have lots of plans to do some secondary analyses to dig into that in more detail and look at the timing of oral switch, compare outcomes with people getting beta-lactam and non-beta-lactam therapy, and a few other things in the oral group.
Oh, that's fantastic. So you have such a rich data set.
I think in that same supplement, there's about 9% of people that had inappropriate initial treatment, and we had to react to that. And so that's just real life. And started the clock from active therapy, as you said.
I think that's what we do too. We do 7 days from active therapy, but it does beg the question, right? If they're better, it's like, could those days have counted?
Rob and Nick, if you could do this over again, your 10-year study, what would you do differently, if anything?
One thing I wouldn't do differently is I wouldn't pick another co-principal investigator.
That is so sweet. Nick's turning red, everybody.
Nick would say the same thing. Like, never do one of these trials on your own. And then if you do, you have to have someone to do it with. Hundreds of people would have joined onto this study in so many countries without the Rob Fowler effect. It never would have happened.
I mean, you guys were tested 10 years of this trial and all the fundraising you had to do and all the logistic nightmares I can just imagine.
Because that's the one thing we both agree on that we would change would be that non-inferiority margin. We really wanted it to be much smaller than previous studies in serious bacterial infections so that we could really know that it was safe to do this. But if we could have just gone with 5% instead of 4%, we would have finished this years ago.
I have to confess, I think in the entire publication, that is the number that jumped out at me, honestly. Like that 4% mortality margin, not many trials in infectious disease had that much courage. 4% is tiny for our typical ID trials. You guys were so intellectually honest. It was so courageous because every percentage point means, God, another year of my life on this trial.
We were trying to see how small we could realistically get that non-inferiority. When you ask people, and it's arbitrary, right? There's no one number, something that seems really high and something that seems that's impossible. But when you're asking people, would you accept, up to 4% difference? People think about that and say, oh, wait a minute. No, I don't want one treatment to be 4%. Okay, what about 3%? And we get down to asking groups of people, and at 1%, people say, okay, fine, 1%.
And you're like, oh my God, I have to randomize the whole North American continent.
You need everybody. But so focusing, as Nick said, on the point estimate eventually, with some degree of confidence around that. If the point estimate was 3.9% absolute difference favoring higher mortality in a 7-day arm, that might not have been very comfortable. And I think we'd be having a very different conversation. Looking at the point estimates, though, and maybe 5% non-inferiority margin, maybe that's a better trade-off than what we initially chose. But as you say, live and learn a little bit, and maybe we do it differently.
Well, guys, congratulations. It's seriously amazing work. It's been amazing discussion. And the time has come for the Breakpoints faithful for the I Feel Nerdy segment of the podcast. I Feel Nerdy is meant to be a safe place and a closing segment for panelists to nerd out over their favorite ID topics, quirks, and fun facts. And this, Angela is making fun of me because so Communicable does the get to know you. It's just supposed to be non-science related whatsoever. And I put this as the get to know you question. And Angela's like, Erin, you're such a nerd. No, the get to know you is supposed to be about concerts. Question is, what's next? What's the next question you want to answer? And it doesn't have to be something you're necessarily already working on, but if money just rained from the sky and you could do any trial in the world that you wanted to do, what trial would you design?
I guess we're pretty fortunate that we somehow gotten funding for that next exciting trial that we do want to do. And the idea there is kind of a traditional single question trial, platform trial, asking multiple questions at once. We're drilling down just to the gram-negative bloodstream infections compared to balance. So it's a little bit more homogeneous, but still a mix of pathogens and sources of infection. And there's 5 questions. The first one would be de-escalation to the blood culture sensitivity result versus no de-escalation. The next one, in people ready to switch to oral therapy, beta-lactam versus non-beta-lactam oral therapy. And then the small subset with a low risk, now that we call them low risk AMP-C organisms, randomizing them to carbapenem versus ceftriaxone treatment. And then there's a diagnostic question, which is, do we need to repeat the follow-up blood culture? And so randomize people to follow-up blood culture versus no follow-up blood culture. And the one syndrome-specific question that we started with, which is the trickiest one to do, is should we replace or retain the central line in a patient with bloodstream infection in the central line?
Wow, I love it.
Okay, so I am surrounded by nerds because Erin's question was meant to be, what trial do you want to do next? And then Nick and Rob's answer is, oh, well, we're already doing it.
His answer was not 1, but 5 trials, which is amazing.
Yeah. Rob, anything you want to add to your dream trial that you're already running?
I mean, there's so many that are important to do, and trying to get to those questions as efficiently as we can. The idea of looking back at answering one main question over about a decade, it's great in a sense, but at the same time, you think, oh my gosh, really? Could we have done something more efficient in this notion of trying to appropriately blend in other questions to a defined patient population, as Nick described in Balance Plus? I think that's clearly where most people are thinking in trials. If we went back in time, Nick, 15 plus years, I think we might tell our past selves, hey, you should consider the approach that people are taking now and Balance Plus is taking. So I guess I would want to highlight all of Nick said and the importance of trying to get through these questions as efficiently as we can.
Do you want to tell about the 6th domain that doesn't exist yet, but that we're thinking of that might be brought up to today's conversation?
Yeah, that's a good point in case it doesn't come up. So I suppose we've kind of implied a couple times during the conversation that shorter is seemingly just as good as longer, in this case 7-14 days, but the notion that we ideally would want to individualize our treatment. It's tough to know when to stop antibiotics, and that's come up a few times, and figuring out the best ways to do that. What patient characteristics, what diagnostic characteristics can we use? And I think a 6th domain that we're working towards is to do something that would be 7 days versus a shorter duration for patients that would be, clinically reasonable based upon, we'll say, likely some degree of improvement and lack of markers that would push us to prolong. Nick mentioned one of the terrific collaborators, Sean Ong. He's also looked at the balance data set to say what happens to patients physiologically and biochemically over the course of their treatment. In an observational over time way, it does seem that by day 4, but day 3 to 5, most people have a resolution in a lot of those things that we would think are signs and symptoms of infection, at least active infection. And so looking at a patient population that by somewhere day 3 to 5, maybe day 4, has improved, could we shorten antibiotics in a group? And so that's probably a next question that we hope to incorporate into the Balance Plus gram-negative bacteremia trial.
I think, Erin, you and I have talked about this on previous episodes, maybe. I'm convinced that with gram-negative organisms, I'm not going to speak for gram-positives just yet, but for gram-negatives, I'm convinced that anything you do after day 3 is probably just detail. I think once you get that bacterial load down in the beginning, I really think a lot of the stuff we do afterwards is just window dressing, oral switch. And with gram-negatives, especially E. coli, in our trial of 500, we did not have one metastatic complication of any gram-negative, not even one. We had some local suppurative, renal abscess next to a pyelonephritis, but we did not have one metastatic complication of any gram-negative. It just doesn't come back to haunt you like the horror show that is Staph aureus. And so I am thrilled to hear that you guys are going to do this. We need to establish the lower limit.
I'm thrilled you're asking both questions because, Nick, you mentioned, which is a burning question in the community of, do I need a fluoroquinolone or trimethoprim sulfamethoxazole, or can I use a beta-lactam? And then, USCAS just did a really nice exploration into the beta-lactam PKPD. And from a PKPD standpoint, the beta-lactams shouldn't work for gram-negative bacteremia, but we use them clinically all the time. Angela and I have talked about this. It's like, is the question fluoroquinolone or beta-lactam, or is the question 4 versus 7 days, right? If you get 3 days of ceftriaxone, does the last 4 days even matter? And so you guys are asking both, which is really cool. And I can't wait to see that come out. Hopefully not in 2035, hopefully before, but we'll see.
Platform trials are more efficient because you can ask more questions at once, but then it can also cause problems because questions can interact and cause each other some difficulties. And why would you randomize patient X to beta-lactam versus non-beta-lactam for that last part of treatment if you would also be willing to randomize them to
3 versus 7 days, right? Exactly, or 4 versus 7 days. So you're right that it is a problem, but it's still pretty awesome.
I will go back and add a little caveat. I really believe strongly that individualizing is the key word. It's not just, let's get to the shortest possible duration, let's get to the lower limit. I still think we need to very carefully look at the pathogen and the host. It's not for everybody to do 3 days. I don't want to be cavalier, but I do think if you use some good clinical sense, right? Biomarkers such as temperature, what are the kinetics of the fever dropping? Simple things like that. I'm not saying everyone needs a CRP, but looking at your patient, listening to your patient, obviously knowing the pathogen, I think that individualization is key, but you can bring durations down in some populations, some infection types, of course.
Well, and not to we're going to have a whole nother hour here on your future trial. We're going to have you guys back in 5 years when you finish this one. But the follow-up blood cultures, thank you for doing that as well. That's very important because I think some of that nuance gets missed. The 2019 landmark gram-negative trial, which we've discussed, that did require follow-up blood cultures. So I have some providers who won't do 7 days without follow-up blood cultures. They're like, I'm in if I follow the trial protocol, which was follow-up. And so I think that's a really important thing to assess too. In my residency, I was taught you never need follow-ups for gram-negatives and you always need them for gram-positives. And the right answer, as with all things, is somewhere in the middle, right? Some gram-positives, you probably don't need to document clearance, and some gram-negatives, you probably should, especially if the source is prostate or something like that can, who knows. But
you have to know that's the one enrolling like wildfire compared to the other domains. So follow-up blood culture is already at its first interim analysis. It passed the 1,000 barrier, so we might have answers for you soon.
Fantastic. All right. Well, guys, this has been incredible. Yes. Thank you so much for the discussion.
So to our 2 wonderful guests, as we wrap up, do you 2 have any last messages for our listeners?
Yes, we got the great fun of being here for this conversation, but we'd like to thank so many people. So I should mention Asghar Rishu, who is our Balance project manager, who coordinated this entire international undertaking. Our brilliant biostatistician, Roxandra Pinto, our amazing Balance steering committee, our wonderful DMC, more than 100 individual site investigators who we're such an honor to meet and work with. And then this incredible group of research coordinators across these 70 plus sites doing all the hard work of screening, enrolling patients and entering data. And then last but not least, 3,600 patients and their families who generously gave participating in Balance and helped push forward the science and antibiotic treatment tradition.
Beautiful. Thank you so much to our guests, Nick Daneman and Rob Fowler in Toronto, Canada. And thank you to Erin McCreary in Pittsburgh, USA, for co-hosting with me, Angela Huttner, in Geneva, Switzerland. Thank you for listening to Communicable, the CMI Comms podcast, and Breakpoints, the Society of Infectious Disease Pharmacists podcast.
This episode was peer-reviewed by Ariana Zerja from Mother Teresa University Hospital Center in Albania and edited by Katie Hosteller-Oy. Communicable theme music was composed by Joseph McDade, and the Breakpoints theme music was recorded by SIDP member Dr. Steve Smoke. You can subscribe to Communicable and Breakpoints on Apple Podcasts, Spotify, or wherever you get your podcasts. Thank you for listening and helping CMI Comms and ESCMID move the conversation in infectious diseases and clinical microbiology further along, and helping SIDP achieve our vision of safe and effective antimicrobials for now and the future.
You guys are awesome. Thank you. I'm so sorry this took so long. It was too much fun.
No, that was so much fun. I think you heard my cough. Unless I was having so much fun, I was coughing and not even noticing that I was coughing.
No, you didn't cough. I actually don't think you coughed even once, Nick. I think we cured you.
Yeah,
I think we have to do this more often.
Yeah.
Thanks for sitting through this, Erin. I don't think we've ever recorded for the almost don't worry, we're going to cut this, but we have never gone to almost 2 hours actual recording time. It's a good thing we did reserve the 2 hours.
Yes, we have, Angela. You and I talk a lot.
I know, actually, yeah.
I'm like,
sorry,
yes,
you guys didn't know what you were getting into.